Welcome back, everyone, to part 7 of our advanced masterclass. Some of these skull-based surgeries can literally last 12 to 15 hours. It's a massive undertaking. So today, we're doing a surgical strike in this explainer to tackle what is arguably one of the most intimidating areas of neurosurgical billing, the complex world of skull-based surgery coding. If you've ever stared at a dense, multi-page operative report full of craniofacial resections, transpetrosal approaches, and intricate dural repairs, and just felt completely overwhelmed, well, you're in exactly the right place. We're going to take all that confusion and turn it into absolute clarity.
We've got a really structured pathway mapped out for today. We're going to systematically break things down, starting with the skull-based triad. Then we'll look at approach codes by fossa, dive into the absolute golden rule, the dural decision rule, cover our add-on and vascular codes, and finally, synthesize the whole thing so you can master the decision tree. Let's get right into it.
Section 1. The skull-based triad. This right here is the foundational architecture of everything we're talking about today.
I want you to mentally scrub in with the surgeon for a second. Imagine you're standing right there in the OR. Every single skull-based surgery naturally breaks down into 3 distinct chronological phases. First up is the surgical approach. Honestly, this is just getting in. The surgeon has to navigate complex bone, nerves, and blood vessels just to reach the site safely. Second is the definitive procedure. Okay, they've arrived at the target. Now what? This is the actual resection of the tumor or the repair of the lesion. And third, we have reconstruction and closure. The pathology is handled, but how do they meticulously put all that complex tissue back together? Approach, definitive procedure, reconstruction. You absolutely must isolate these 3 phases in your operative report to code this accurately.
Moving on to Section 2, Approach Codes by Fossa. Let's talk about how the actual anatomical geography of the cranial floor dictates that first phase, getting in.
Think of the skull base as the literal floor of the skull. It's packed with vital tunnels and passageways for central nerves and blood vessels. Now, the surgeon's entry route depends entirely on where the target lesion is hiding, and we divide this into 3 main zones, or fossae. First, you have the anterior cranial fossa. That's the front, up near the eyes and nasal cavity. Next is the middle cranial fossa. This sits near the temporal lobe and the cavernous sinus, a really delicate area holding major nerves for eye movement and the vital carotid artery. And finally, the posterior cranial fossa at the back, down by the cerebellum and the brainstem, right where the spinal cord meets the brain at the foramen magnum. Knowing exactly which of these 3 zones you're in is non-negotiable for coding the approach.
So how does this anatomy translate into your billing data? Well, we use our approach codes, spanning from 61580 to 61598. If your surgeon is working up in the anterior base, you're pulling from codes 61580 through 61586. Think of your craniofacial, orbitocranial, or those extensive Leefort eye approaches. Moving to the middle base, you'll use 61590 through 61592 for infratemporal pathways near the ear. And for the posterior base, we assign 61595 through 61598 to capture those incredibly deep, complex pathways down near the brainstem. It's really just a matching game. Match the entry method described in the op report to the correct anatomical zone.
All right, Section 3. This is the big one, the dural decision rule. This takes us into the second phase of our triad, the definitive resection. For this phase, your entire coding logic hinges on one absolutely critical clinical boundary. If you remember nothing else from this explainer, remember this single question. Was the dura opened? The dura mater is that tough outermost membrane protecting the brain and spinal cord. I really cannot overstate this. The integrity of that dural membrane dictates your definitive code selection. Period. You have to scour the operative note to see if the surgeon intentionally incised the dura or if maybe the tumor had already invaded through it, requiring a dural resection.
Here's exactly how that rule splits your codes. If the lesion remains totally outside the dura, meaning it's extradural, the membrane was not opened, you use a lower complexity code set. That's 61600 for the anterior, 61605 or 61607 for the middle, and 61615 for the posterior. But if that membrane is breached, the clinical risk skyrockets. It instantly becomes an intradural lesion, mapping to your higher level codes, 61601 for anterior, 61606 through 61608 for middle, and 61616 for posterior. Your accuracy here literally lives or dies by identifying this dural involvement.
Section 4. Add-on and vascular codes. Because these surgeries rarely happen in isolation, right? We have to capture the full scope of the work. These procedures are massive, multidisciplinary undertakings. You've got to actively hunt through the operative report for additional interventions.
For example, did the surgeon have to manage major blood vessels? Carotid artery ligation maps to 61611, while a complex carotid aneurysm or AVM repair within the skull base maps to 61613. Plus, we have strict rules for our add-on codes. If they pull in an operating microscope for microdissection, you capture plus 69990. And remember our golden dural rule we just talked about? Well, it applies here too. If the surgeon uses stereotactic computer navigation, you have to choose between plus 61781 if the procedure is intradural or plus 61782 if it stays extradural. The clinical logic just stacks so beautifully.
Finally, we hit the third part of our triad, reconstruction and closure. Often, these intense procedures result in a cerebral spinal fluid, or CSF, leak that requires a secondary repair of the dura. Your coding here depends completely on the blood supply of the tissue being used. If the surgeon uses a free tissue graft, meaning tissue taken from somewhere else in the body that doesn't keep its native blood supply, you assign CPT 61618. But if they use a vascularized pedicle flap, where the tissue is rotated into place but its original blood vessels stay attached to help it heal, you assign the higher valued CPT 61619.
Let's bring it all together. Section 5. Master the decision tree. We're going to synthesize this entire journey into a foolproof, repeatable algorithm.
This is your ultimate 5-step playbook. Every time you read a Skullbase Op report, process it in this exact order. Step 1. Identify if the surgery is an open approach or endoscopic. Step 2. Determine the fossa. Are we in the anterior, middle, or posterior base? Step 3. Match the specific surgical route to assign your approach code from the 61580 series. Step 4. Stop and ask the golden question. Was there a dural violation? Use that answer to assign your definitive resection code, splitting extradural from intradural. And finally, Step 5. Evaluate the notes for those secondary vascular procedures, reconstruction flaps, and add-ons like microdissection and navigation.
When you systematically stack these logical checkpoints, the guesswork just completely vanishes. Applying this structured pathway really does demystify even the most intimidating, multi-page operative reports. You're no longer just staring at a wall of dense medical text. You're tracing the surgeon's exact chronological and anatomical steps, and you are transforming that complex data into incredibly accurate, confident coding.
So, the next time you get one of these massive operative reports on your desk, ask yourself, are you just reading words, or are you truly tracing the surgeon's blade? Keep building those coding decision trees, stay laser-focused on the clinical pathways, and as always, decode healthcare with Harshal.